Thanks again for inviting me, and I'm glad to present our data on detection of secondary CNV in chronic CSCR by swept source OCTA. I already introduced our study group, and I already said that we currently sponsored by Topcon Europe. So I'm not sure if it's that imperative to differentiate between spectral-domain-based and swept source-based technique in this elusive entity, because the detection rate is quite similar, and also the results regarding sensitivity and specificity are quite high, and they are at least comparable to what we consider standard imaging, and sometimes even higher. Actually, I wanted to emphasize on your paper, the most recent paper on that topic, similar design study in December 2017. I think it was Journal of Ophthalmology, because there was a lower detection rate, but that was obviously due to these silent CNVs, and you were much more accurate than me, that I could do it anyway. So this is our study protocol. We diagnosed chronic active CSCR by conventional angiography, and we differentiated between CNV type 1 and what we call polypoidal choroidal neovascularization, and they were reevaluated by swept source OCTA. We used spectralis from Heidelberg with an eye tracker with a 30-degree picture and simultaneous OCT-B scan, and we compared that again to the swept source Topcon Triton. In this case, we used all available macular cube sizes, and we used the automated artifact removal option. Again, we did the semi-automated segmentation and then sometimes the manual resegmentation and a masked binary grading, CNV positive or negative. Chronic CSCR was defined as visual symptoms for more than 6 months with persistent subretinal fluid or neurosensory detachment, a teardrop or flask shape in blue peak autofluorescence, leakage and or staining in fluorescence angiography, and hyperpermeability in ICGA. We evaluated 24 eyes and 24 patients. 46% of them had bilateral involvement. 18 of them were diagnosed on the first visit between March and November 2016, and 6 were already under observation for a mean of 26 months, and that means all 6 of them had already undergone treatment. This is the descriptive data of our patients, mostly male. They were quite younger. I want to give you some quick examples. This is a 66-year-old male with chronic CSCR for 22 months. So remember, this has already been treated. And what you see is this gravitation line of the demarcated subretinal fluid. You have a speckled type of fluorescence that intensifies in later phases. There is some leakage here that might be due to some fibrin staining. In ICG, you can clearly depict the CNV, the vessel membrane, and you have the hyperpermeability. So this is what we consider CNV type 1 in chronic active CSCR. And we did a segmentation, and we altered the segmentation line through the subretinal fluid. This was a 9mm cube, and you don't see any CNV vessels. But if you go down a little further to the choriocapillary slab, you see quite well-defined filamentous, long vessels, not very dense. And if you do a 4.5 slab, you can even see that better within a black halo. So that is definitely CNV. Another patient with a 73-year-old male with chronic CSCR, and you can already see some kind of orange nodule here in the middle above the fovea. This is blockage in autofluorescence. You have those gravitation lines from long-standing fluid. There is staining in the early phases, but also some speckled type of fluorescence surrounding that is intensifying in later phases, and you have an polypoidal or aneurysmal vessel here and some hyperpermeability. So that's what we consider polypoidal choroidal neovascularization. And when we did the angio, we can clearly depict the pathological vessels underneath the projection artifacts from the inner layers. And when switching to the other retina slab, all other artifacts getting removed. And you see a branching vascular network perhaps, definitely a CNV, but you don't see the polyp itself. So that is CNV at least. That's another interesting case, a 61-year-old male with chronic CSCR and some neurodegeneration here, RPE loss, better visualized in the blue peak autofluorescence. And you have the speckle type of fluorescence here in the angio. You have some late leakage in this area. There is some ill-defined vessels here maybe, but definitely a hot spot in late ICGA. So we consider that to be CNV in chronic active CSCR. And when we did all kinds of segmentations through the choroid, through the outer retina, we did some smaller slabs, and we couldn't find any CNV. So does that mean there is no CNV? We found 8 eyes complicated by secondary CNV due to chronic CSCR, meaning 33%. It was 6 CNV type 1s and 2 PCNVs detected. 7 of them could be confirmed by ISSOCTA. That means a sensitivity of 87.5%. And no CNV could be identified by swept source OCTA in eyes without evidence in fluorescence angiography. So that's 100% specificity. To conclude, in our study, swept source OCTA was inferior to angiography for the detection of secondary CNV in chronic active CSCR, and angiography still remains, I don't know if it's the gold standard, but at least it's the standard that we're measuring at the moment. Polypoidal CNVs were difficult to detect by swept source OCTA alone, but it is a non-invasive, it is a fast, safe detection device, and it should be installed as an additional first-line imaging tool. And unfortunately, because this paper is under review, I can't give you an abstract, but I want to discuss if the specificity of OCTA is high enough in an elusive entity with difficult clinical expressions. And that means if we see something, is it CNV? I would say yes. Is sensitivity of OCTA high enough to detect CNV reliable and isolate them from regressed lesions? Well, I'll give that a plus minus. So if we don't detect anything, then is there not anything? And is dye-based angiography in an OCTA era still legitimate? Well, we don't know, but the future will tell. Thanks for your attention.